All right, welcome back. Today, we're going on a bit of a diagnostic hunt. We're looking for the hidden and, often totally curable causes of high blood pressure. This is one of those chases that can genuinely change a patient's life. Listen up. If the blood pressure is resistant or starts too early or too late, you have to hunt for secondary causes using ABCDE. A is for apnea and aldosteronism. B is for Bruits. C is for coarctation and catecholamines. D for drugs. E for endocrine. Whoa, okay, that's a lot, right? And it's coming at you fast, but that's the point. That's the intensity you need when the stakes are this high. But hey, don't worry, we're going to slow this way down. We're going to take every single piece of that rapid-fire briefing and decode it piece by piece until it's a framework you won't forget. So let's dive in. And you know the drill. Before we get started, just a quick reminder, this is all for educational purposes. It is not medical advice. Please always consult your official guidelines and specialists when you're making clinical decisions. Okay, so first things first, how do you even know it's time to start this whole investigation? When do you look at a patient's high blood pressure and think, something else is going on here? Well, take a look at this. About 90% of all hypertension is what we call primary or essential, meaning it just kind of happens. But that other 10%, that's the secondary stuff. That's what we're hunting for. And why does it matter so much? Because these cases have a root cause we can often find and fix. So that brings us to the big question, right? What are those specific triggers? What are the red flags that should be waving in your face, telling you to start the hunt? There are a few really big clues. First, think about age. If someone develops hypertension when they're really young, say under 30, or much later in life, over 55, that's a flag. Second, if their blood pressure was fine on meds and then suddenly goes haywire, you should get suspicious. But the biggest trigger of them all is a condition called resistant hypertension. So what exactly is resistant hypertension? It has a super specific definition. It means a patient's blood pressure is still hanging out above 130/80, even though they are on 3 different blood pressure meds. And critically, one of them is a diuretic. When you see that combo, that's your green light to launch the full ABCDE investigation. So now, let's get to the good stuff. Let's crack the ABCDE code. Think of this as your diagnostic toolkit, the roadmap for this entire hunt. And here it is, the ABCDE mnemonic. A is for apnea and aldosteronism. B stands for Bruits, which should make you think of bad kidneys. C is for catecholamines and coarctation. D, a huge one, is for drugs. And finally, E is for other endocrine causes. This is it. This is our checklist. Let's kick it off with A for aldosteronism, or Conn syndrome. Now, the key to cracking this case isn't just one lab value, it's the ratio between 2. In primary aldosteronism, the adrenal gland has gone rogue, so it's pumping out tons of aldosterone. That makes the aldosterone level high. In response, the body slams the brakes on the whole system, so renin levels get suppressed, and they're low. A high aldosterone to renin ratio, that's your smoking gun. And here is a massive clinical pearl, a common trap people fall into. We're all taught to look for low potassium with this, right? Hypokalemia. But the truth is, a lot of patients with Conn syndrome have totally normal potassium levels. So please, don't rule it out just because the potassium looks fine. If you're suspicious, that aldosterone to renin ratio is the test you need. All right, moving on to B for Bruits, which points us straight to the kidneys, specifically renal artery stenosis. And what's so fascinating here is how the cause is totally different depending on your patient. In younger women, you've got to think fibromuscular dysplasia. It gives this classic string of beads look on imaging. But in older men, especially smokers, you're almost certainly looking at good old-fashioned atherosclerosis. And speaking of the kidneys, this right here is a massive, massive clue. If you start a patient on an ACE inhibitor and their creatinine suddenly jumps by more than 30%, you have to suspect renovascular hypertension. I mean, that lab value is practically screaming at you that the kidneys are the root of the problem. Next up, C is for catecholamines, which leads us to the rare but classic Pheochromocytoma. This is a tumor that secretes adrenaline, and the symptoms are known as the 3 Ps: palpitations, perspiration, and pain, as in a killer headache. The key thing to remember is that these symptoms often hit in these sudden, dramatic attacks. Now, if you suspect a Pheo, the order you give medications in is absolutely critical. You must give alpha blockers before you even think about giving beta blockers. If you do it the other way around, you risk what's called unopposed alpha constriction, and you can send the patient into a catastrophic hypertensive crisis. This is a life-saving pearl. Always, always alpha first. Okay, so we've hit the highlights for A, B, and C. And don't forget D for drugs and E for endocrine are just as important. You have to get a good medication history, including stuff like NSAIDs, and always keep those other endocrine issues in the back of your mind. Now let's do a quick fire round to lock this whole mnemonic in place. Ready? Let's make this stick. A is for apnea. Think sleep apnea. It's one of the most common causes we find. B is for Bruits. You're going to listen over the kidneys for that telltale whooshing sound.
C is for coarctation. You're going to feel for that classic delay between the radial and femoral pulses.
D is for drugs, a deep dive into everything the patient is taking, prescription, over-the-counter, everything.
And E is for endocrine. This is our bucket for Conn's, Cushing's, thyroid problems, the whole hormonal shebang. There it is. The hunt is on.
So now that you have the toolkit, we want to hear from you. It's your turn to share some stories from the trenches. And that brings us to our question of the day. Have you ever cracked a case of resistant hypertension and found that the culprit was obstructive sleep apnea? It happens all the time. Let us know your story in the comments. Thanks for joining the hunt today. Next time, we're going to talk about choosing the right weapon to bring that pressure down. See you then.